Thanks everyone for coming. Can you hear me okay? Is this going? Perfect. There we go. So just a little introduction. Thank you, Kathy, for the kind introduction. Thanks to the Sanford team for putting this together, CSF, Kathy for flying in and helping us set up things. Obviously, I'm not the new young guy in town. I've been doing this for about 25 years. I was in Florida for my entire career prior to this. I'm originally from Minnesota, so this was sort of coming back home. My wife's Canadian, and we've been appreciating the cold the last couple of days. In terms of my training, this congenital neurosurgery thing is sort of something I stole from the cardiac surgeons. The idea being, regardless of a patient's age, we think most patients with Chiari were born with Chiari, and so having the additional training in that specific disease process benefits patients, and so Chiari is something that I've really been passionate about for many years now. And we're working on bringing this over to Sanford. One of the things that Sanford worked well with me, just like Florida Hospital where I was before, is one of the things a surgeon wants is consistency in the OR. And here, although we have the Castle and we have the adult hospital, the ORs are the same. So whether I'm operating in a 3-year-old or a 103-year-old, I have the same neurosurgery team the whole time. So from an intraoperative standpoint, that helps the surgeon a fair amount, which is why this congenital thing works better here than, for instance, at Boston Children's, which is a freestanding children's hospital, or many of the freestanding children's hospitals. We're just going to move through here. So this is my first talk in South Dakota, so I'm going to do some similar discussion on what I've had in previous talks, just sort of some baseline. I assume most of the people here are relatively educated on Chiari, but this is going to give us sort of a baseline with which to speak and phrasing to use. So Chiaris, if you get online and look at them, there's 4 different types of Chiaris. Really the focus of this discussion today is going to be a Chiari 1 malformation. It's by far the most common malformation, and it's what we deal with the most. Chiari 2, very common in the spina bifida patient population. 3s and 4s, very rare, essentially terminal conditions. So it's rare that these patients survive after delivery. Most of them are stillborn. So we're going to be talking about Chiari 1s here. So I started my training in 1990. MRIs had only been out since the 80s, and so that's part of the frustration. What Kathy's talking about is trying to get more research going. We'll talk about sort of where we've been going over the last 25 to 30 years, but we're still in our infancy in trying to learn what the best treatment for Chiari is, and in fact, whether Chiari is symptomatic in many patients or not. So for most of us, the skull ends, then the brain ends and the skull ends. All of our brain is within the skull. For a small percentage of the population, depending on what study you look for, up to 3 to 5% of the population, the skull ends and the brain ends. The little piece of the brain, the cerebellar tonsils, goes through the foramen magnum, the hole at the base of the skull. It's the only hole in the skull that brain can go through normally. So when I was in training, any bit of cerebellar tonsillar ectopia was considered a Chiari 1 malformation. About 7 or 8 years ago, that definition was changed to need to be more than 5 millimeters. That's why I put up on here requiring greater than 5 millimeters of cerebellar tonsillar ectopia. That's the current definition. So if you look at the CPT codes, the way we code patients, if you're not more than 5 millimeters, you don't technically meet that definition. That was chosen simply because of population dynamics, not specifically because of patients under 5 millimeters can't be symptomatic or patients over 5 millimeters have to be symptomatic. And so understand this is really a semantic discussion, and I've seen a lot of patients get stuck into, well, the doctor said I'm only 4 millimeters, so I must not be symptomatic with my Chiari. Or I'm 20 millimeters, so I must have to have something done with the Chiari. While an MRI is important, while the imaging is important, clearly the patient's symptomatology is the most important part of this whole thing. So we do want to look at the degree of cerebellar tonsillar ectopia. In general, A 5 millimeter cerebellar tonsillar ectopia is less likely to be symptomatic than a 50 millimeter cerebellar tonsillar ectopia. And yes, I have seen them that much as well. But you can be symptomatic and be 1 millimeter, and you can be asymptomatic and be 20 or 30 millimeters. So again, it's just important to pay attention to all that stuff. So this is really a definitional issue. It's a semantic issue. It's not a scientific issue. So you'll hear people use different terms. Again, 8 years ago, if you had 4 millimeters of cerebellar tonsillar ectopia, you would have been a Chiari 1. Now, your cerebellar tonsillar ectopia, we really don't have a definition for you. So the phrase I use, the phrase many of us in the Chiari world use is Chiari 0, but there's not a federal government approved terminology like that. So Chiari 0 is sort of a default that many of us use for the 0 to 5 millimeter Chiari 1 patient population. Used to be Chiari 1s on everybody. So again, anatomical issues for most of us, brain ends and the skull ends, so we want a nice smooth contour to the cerebellum. In this picture, in this MRI, skull comes down here, brain comes down here. We pay a lot of attention, I just paid a lot of attention to the degree of cerebellar tonsillar ectopia, and now I'm going to tell you that that's not that big a deal. We need to be paying attention to other things. So this is a classic patient who has beaking of the cerebellar tonsils, and you see a significant indentation of the skull there. So of the brain. The brain should have a nice smooth contour here. This is the Chiari 1 malformation, what that yellow is pointing on you. In adults, it should be pretty static. In kids, we expect it to change. Specifically, it should grow commensurate with the patient. So I always emphasize, look where it is anatomically. This is the foramen magnum. This is the posterior arch of C1. So in this patient, the cerebellar tonsils are going down to the posterior arch of C1. In kids, that may be 2 or 3 millimeters if you're a 2 or 3-year-old child. And so that 5 millimeter definition is even less helpful in kids than it is in adults. We expect to see growth commensurate with patients. So I tend to follow my patients with serial MRIs at least for a couple of years to make sure that things are stable, even if they're doing fine. If we see further cerebellar tonsillar ectopia, that makes us worried. That doesn't mean that the number is bigger. It means that it's going down further into the spinal canal. So you would expect a child who's 2 feet tall and has 2 millimeters of cerebellar tonsillar ectopia, when they're 5 feet tall, if you have growth commensurate with the patient, they would have 5 millimeters of cerebellar tonsillar ectopia, right? It should grow similarly. So that's why it's important to be looking at where it is. And most radiologists don't read where it is. They just read the degree of cerebellar tonsillar ectopia. This gets back to what Kathy talked about, which is trying to get us all to use the same lingo. And we're still not there yet, but we're working on it. So symptoms, pretty classic. This classic suboccipital headache is what we're looking for. Right, this is an abnormality of the back of the head. If it's classic, it's simple to figure out. Most patients aren't classic, and so it's not as simple to figure out. Anything that raises your intracranial pressure, any Valsalva maneuver, coughing, sneezing, straining to have a bowel movement, that's essentially pushing the cork down further. So if we picture the cerebellar tonsillar ectopia as a cork, you raise your intracranial pressure, you're pushing that cork down further. And so classically, symptoms are made worse by Valsalva maneuvers. If you have a syrinx, the syrinx is spinal fluid in the middle of the spinal cord. The center of the spinal cord is your pain and temperature sensation. So classically, pain and temperature are affected by syrinxes as well. And then we worry about drop attacks. Is there pressure on the spinal cord itself? Once we're seeing, and we're going to talk about the Chiari Severity Index as we go along, but once we see the spasticity, dizziness, balance issues, a lot of these things are myelopathy. It's evidence that the spinal cord itself is not working. And we worry once you're getting that far that there may be some permanent damage that we're missing. So we want to ideally catch patients up here rather than having them come down there. So in adults, and again, kids and adults present differently, even though it's the same series of anatomically similar. Adults classically have headaches. You don't have a 2-year-old coming up saying, "Mommy, I have a headache," very often, particularly if it's something they've been living with their entire lives. So headaches, neck pain, oftentimes these are precipitated by trauma, and we'll talk about that a little bit, but where the cerebellar tonsils are is supposed to be spinal fluid. In Chiari patients, the definition is it's the bottom of the brain, so you have less of a shock absorber capacity in that location. In kids, we'll often have issues with brainstem findings, so swallowing issues, coordination issues, central sleep apnea. I've never had any of my Chiari patients die, but there have been, God willing, never will, but there have been case reports of kids going to sleep and not waking up. So central sleep apnea, where you have pressure on the brainstem, that would be considered an indication for urgent, if not emergent, decompression. I've had a number of kids come to me in the past who look fine neurologically, have never been able to swallow well, have a G-tube in, have some spasticity, and their issue was not a GI issue, their issue was a brain issue. Once they were decompressed, they were able to get rid of the G-tube and all those. So one of the things we work on with our GI fellows is trying to make sure that we're getting MRIs on these patients before we do any surgical procedure on them, any GI surgical procedure on them. So diagnosis is radiographic. CT is really hard to call. Some radiologists are pretty good at it, some radiologists not as good at it. MRI is diagnostic. So a head MRI is a diagnostic test of choice. We usually look at the midline images. Again, this is the same MRI, looking at that cerebellar tonsillar ectopia. I'm sure many of you have had similar issues where you had an MRI 6 years ago, it was read as normal, and then you get a repeat MRI and they say, "Oh, you've got 6 millimeters of cerebellar tonsillar ectopia." You see the neurosurgeon, they said, "Yeah, it was there 6 years ago." Well, why didn't they mention it? A lot of the radiologists aren't looking at that, so it is important to look at the MRIs, and if they are doing this for a Chiari, to make sure that the radiologist knows what he's wanting to look at. So again, this is if we're doing a head MRI and this is the bottom of the brain, sometimes they just don't read it all the way through, and it's frustrating, but medicine is imperfect. So once the diagnosis is made, where do we go? When do you want to see a neurosurgeon? So the neurosurgeon sort of wants to figure out what's going on with the patient. What's the history? Is there evidence, again, evidence of myelopathy, evidence that their spinal cord isn't working properly? When did they walk? When were they potty trained? Did they have any central sleep apnea, any swallowing issues? Where is their pain and what are their fine motor skills? So many of these patients have diminished fine motor skills. Fine motor tends to be more affected than gross motor skills. You don't automatically need to see a neurosurgeon if you have a Chiari. If you're asymptomatic and it's picked up because you had a trauma, we have a lot of that, so you get a head CT, they can't tell if you have a Chiari or not, they do a Chiari. If they do an MRI, you've got a Chiari, but you're asymptomatic, then you don't need to see a neurosurgeon. Most neurosurgeons will be happy to see you and clear you. But if you're asymptomatic, you're not going to do anything for the Chiari, barring any specific findings on the MRI. So when we see patients, some of it's just simple. You see them walk in, how are they doing, what's going on with the walking. You're looking for changes. Again, you're looking for pressure on the spinal cord. So how do we see that clinically? Your reflexes. If you're hyperreflexic, that gets you into myelopathy. We'll talk about, again, I mentioned earlier, the Chiari Severity Index came out 3 or 4 years ago. But there's clear evidence in the literature now that by the time you're myelopathic, your success for treatment is diminished. And so we think this means that there is some degree of permanent neurological damage that occurs that's below the level of resolution of the MRI. So the MRI is the best anatomical study that we have. It's clearly not perfect, and if we look at things at a cellular level, we may be seeing more. So similar to reflexes, we're looking at tone. If they're too tight or if they're too loose, what's going on with their muscles there? Embryologically, the skin and the central nervous system come from the same series of cells. So we're looking at cutaneous stigmata. That means, is there a change in the skin along the bottom of the skull or along their back, midline, that would be concerning? So it's easy for me, not everybody has my haircut, but when I shave a little bit of hair For surgery, I shave just because it makes things a little bit easier for closure intraoperatively, so I usually shave a little bit of hair. We see these suboccipital hemangiomas in many patients, what we used to call stork bites in the back of the head. And it's shocking to me the number of families that come in that say, oh yeah, that's our family birthmark, everybody has it. Well, not everybody has it, and if you have it, it can be evidence that there is something abnormal underlying in the brain. And again, that's because embryologically, the skin and the central nervous system come from the same series of cells. Same thing with the tethered cord. So if you've got an abnormality down at the low part of your back, particularly from the hips down, we want to be sure that we're not missing anything like a tethered cord or a syrinx, anything like that. So that's one of the reasons we tend to do a full MRI on all of our Chiari patients as well. The sensory disturbance we talked about, if you have a syrinx, pain and temperature tend to be affected a lot. Proprioception is knowing where you are in three-dimensional space. So a lot of the times the parents will come in and say, Johnny's fine during the day, but turn off the lights and Johnny has no idea how he is walking. And that's because Johnny's using his eyes to figure out where he's going and what his legs are doing. For most of us, we close our eyes and we can walk and we're okay. If you don't have proprioception, if you don't know where your body is in three-dimensional space, you need the other senses to make up the difference. And so that's the proprioception issue. And then scoliosis is a relatively common thing, but if we see atypical scoliosis, this then comes to the rule of 20s. So about 20% of patients with scoliosis will have an intradural anomaly. Chiari is the most common, but syrinx, tethered cord are concerns as well. So assuming it's not a classic scoliosis, and I think the orthopedic surgeons are doing MRIs on virtually everybody now. Classic scoliosis, a little bit of curvature in a 13-year-old girl, a teenage girl is more common. Certainly in any male, certainly any age above or below, they need to have an MRI, and the orthopedic surgeons are usually doing those. A different rule of 20s is about 20% of Chiari patients will have some additional neural axis anomaly, so some intradural anomaly. 20% will have a syrinx or a tethered cord. So tethered cord means that your spinal cord is literally being pulled down. The most common finding is a fatty filum terminale. The filum terminale I describe as the appendix of the central nervous system. We think it went to our tails when we had tails a million years ago. But it doesn't have any neurological function now. It is the last nerve made in the central nervous system. So if a cell which was meant to get to the surface didn't get to the surface, it can cause tethering. It cannot stretch to the same degree that the nerves around it will. So fat, remember, central nervous system and skin came from the same series of cells. If a cell of fat gets stuck in there, and then obviously as the fetus matures, there's more than one cell in there, that fat will tether the spinal cord, will keep it from growing normally. And so by pulling things down, you can literally pull down the Chiari as well. It's why we think the Chiari 2 is present in most of the spina bifida patient population, because their spinal cord is, by definition, tethered in almost all the patients. It's pulling things down. Now in the Chiari 2s, they have some other anatomical abnormalities in the hindbrain, and essentially everything is being pulled down. So it's a little bit more anatomically different, but similar kind of issue. If you miss a tethered cord and you decompress a Chiari, the goal of the decompressing the Chiari is to give the bottom of the brain more space. If you give more space and you're still stuck down, what happens? Things get pulled down. So that's why it's important to make sure that you're not missing a tethered cord before you do a decompression. So I don't decompress anybody before I get an entire spine MRI to make sure we're not missing something else there. So generally, a decision to operate is based on symptomatology. You want, remember, you have a neurosurgeon talking to you here. The surgeon always wants to operate, right? So take everybody with a grain of salt. But in general, you want to make sure that you've achieved maximal medical management. You want to have done everything you can to make sure your symptoms are coming from the Chiari and can't be fixed any other way medically is really what we're talking about here. So the only way to directly affect a Chiari, because it's an anatomical abnormality, is surgery. there is no way to tell 100% if the symptoms are coming from the Chiari. And so it's important to make sure you've achieved maximal medical management, gone down the neurology pathway, and the symptoms either are progressive or not getting better and still significantly affecting your life. So what we look at, again, classically, we've got the suboccipital headaches worsened by Valsalva, brainstem symptoms. So if we see that, central sleep apnea, that's one of those I don't give my families a choice. Again, the last thing I want to do is have a kid die on me. So central sleep apnea plus Chiari equals surgery. Truncal symptoms, so we talked about scoliosis. Bowel and bladder incontinence. We talked about the last nerve that comes out is your filum terminale. The last functional nerves that come out are those that go to your bowel and bladder. And so if you have bowel and bladder dysfunction, it raises concern that there is pressure on the spinal cord. And remember, the Chiari is either the bottom of the brain or the top of the cervical spine, whichever way you want to look at it. It's anatomically the same location. And then again, you want to make sure that you've achieved maximal medical management, assuming you're not worrying about some life-threatening issue or something else like that. There are instances where we look at the MRI. I meet the patient, I look at the MRI, and I say, okay, when are we going to schedule surgery? That's the rare patient. The vast majority of patients are based on symptomatology. But there are things that we worry about on the MRI that we would push the patient towards surgery. If you have an enlarging syrinx, if there's a fluid-filled cavity in the spinal cord and it's getting bigger, we're going to push you in the direction of surgery because we worry that at some point you're going to fall over that cliff. There's going to be enough pressure in the spinal cord that there's going to be permanent damage that we can't reverse with surgery. Same thing with signal changes in the spinal cord. Signal changes mean that you're seeing pressure on the spinal cord and swelling on the spinal cord, so you're seeing damage going on already. Cine studies are a little controversial there. Cine studies, flow studies, cine from cinema. You're looking at the flow of the spinal fluid at the craniovertebral junction where the Chiari is, but there's pretty clear literature. If you have diminished flow at the craniovertebral junction from the Chiari, you are more likely to have good outcome. Truth is, I don't use cine study in unoperated patients very often because it's really dependent on their symptoms more than anything. I like using the cine studies in the post-op patients who look like they're very well decompressed and have recurrent symptoms. So we'll often see abnormal flow posteriorly in the area where the Chiari was decompressed. So even though it looks good, doesn't mean you have normal flow in that area, and you can have scar below the level of resolution of the MRI. Again, MRIs are great, but they are not a panacea. They don't show us everything. So if you have abnormal flow back there, we expect to find scar when we go intradurally to look. And then if you have progressive cerebellar tonsillar ectopia, so we talked about I like following my patients with MRIs. A single picture doesn't tell the complete story on anybody. So my default, and there's no great science behind any of this, so we've talked about trying to improve our literature and know what we're doing a little bit better, but my default is I do MRIs at 6, 12, and 24 months after I meet the patient if they're doing well, and we're not talking about surgery, but that tells us that there's stability. And the logic between that is the first interval at 6 months, if we see stability, we say, okay, things are stable there. We do another one 6 months out from there. We then have 12 months of stability. If we have 12 months of stability, we do another one after that. At 2 years of stability, it's unusual to see significant changes. Again, kids are a little different, but that's what I do in the adult world. Most of us now do the same surgery, do similar surgery, and I'll talk to you about why I do what I do, and we'll talk about, have some specifics about the surgery. But we all do at least the beginning part the same. So there's a midline suboccipital dissection. About a year or two ago, I saw a publication talking about a minimally invasive Chiari decompression, and their minimally invasive was a 2.5-inch incision. I thought, I've been doing this for a decade with a 2.5-inch incision. I just don't consider it minimally invasive. It's just an appropriate decompression. So midline suboccipital incision, we usually go from the inion, the little bump you can feel on the back of your head, to your hairline. The goal is to get down to the skull. We do a 2.5 centimeter by 2.5 centimeter suboccipital decompression. So that's pretty good literature to say that's the size of the decompression we need to see. Depending on your degree of cerebellar tonsillar ectopia, many of us will take off the posterior arch of C1, so the top of the neck. Obviously, we want to preserve as much normal anatomy as possible. Conversely, we want to be sure that the patient's completely decompressed. In my case, and I'm going to talk about it in the next couple of slides, I always recommend dural opening in my non-syndromic patients. So if you're syndromic, if you're an achondroplastic dwarf, if you have a craniofacial dysostoses, if you can clearly say this is definitely from the bone, those patients I don't open the dura, but I recommend opening the dura in the rest, and I'll talk about why we do that. Most of us do a cytoreduction of the cerebellar tonsils, so you'll hear people say you cut out the tonsils. You don't really do it. You use little bipolar electrocautery and you shrink it down. And the pia is the covering, so it's a subpial dissection. The advantage there is also you can open the obex. The obex is the outflow of the fourth ventricle, so spinal fluid is made in the lateral ventricles, circulates down the third and the fourth to go into the spine. So the fluid that's in your spine is the same fluid as in your head. If the Chiari functions as a cork and blocks the flow of spinal fluid, that's when you start getting syrinxes, because it can't get outside the spinal cord, it is being forced inside the spinal cord. So by opening the obex, we're able to confirm good spinal fluid flow in that area. And then obviously you need to close the dura, and we'll talk about different patches. I've been using autologous muscular fascia for the last decade or so. Dura is meant to hold spinal fluid in space. It has a texture similar to skin. The covering of the muscle is the autologous muscular fascia. We have to move the muscles to the side to get in. We put them back when we're done. If you take a little piece of the muscular covering, it has, again, a very similar texture, and it grows back. So if you were to go back within a month, you wouldn't be able to see where you had harvested it. So there's lots of literature out there in terms of success rates. There's pretty good literature that syrinx will reduce in size in more than 90% of patients. And again, this was published a decade ago now in 2008. If you do an adequate decompression, the problem is how many patients are going to improve in their preoperative symptoms. We're doing this to try to get patients better. It's rare. I've never seen anybody get worse, so it would be rare that patients get worse. But you don't want just stability, you want patients to improve. So literature has anywhere from 50 to 90% of patients getting better, and that probably is somewhat related to exactly what we do. So part of this Chiari Severity Index came out in 2015. It was done by the WashU guys in St. Louis. And basically this data is just coned down into this data. And what they did was, these are all Chiari 1s, okay? Again, remember we're talking about Chiari 1 patients. They graded Chiari 1 patients in 1, 2, and 3. If you had a classic Chiari headache or just had a headache that wasn't well localized, surgical decompression was successful in 81% of patients. If you had a frontotemporal headache or no headache, you fell down to 66%. And if you were myelopathic, we talked about myelopathy. If you were spastic, if you had breathing issues, swallowing issues, the success rate dropped dramatically down to 58%. So the question is, when do you go from that 81% to the 58%? And we don't know, but we'd obviously clearly rather catch people at the 81% rather than the 58%. Usually what I talk about is 80% and 60%. This article's very specific on it. So again, why do we do what we do? We're trying to maximize the chance that you get have a single operation to improve, trying to minimize complications, right? The Hippocratic Oath, first do no harm. Most common complication in any operation is bleeding and infection. The blood loss with the Chiari operation is low. It's 10 or 20%, so it would be rare that that's a significant issue in anybody. We obviously check blood work and make sure that everything's as safe as possible for you. These all require general anesthesia. The risk of infection is about 1%, and that's just because we've cut the skin open. So that risk is there. Because we go down to the dura, whether we open the dura or not, we're down there. So if you get an infection, there's a potential risk of meningitis. Meningitis is the covering, is the dura itself. So obviously we want to do everything we can to minimize that risk of infection. there's also a risk that the patient may fail to improve. So here, I know these are very busy slides, but this is a conversation I used to have with patients. And the part that's red was talk about, this is an article that came out in 2000. Should we open the DURA or should we not open the DURA? This is an ongoing discussion that we have. So here, if you decompressed and did the duroplasty, 87% improved. Here, 73% improved if you didn't open the DURA. Some improvement, not enough numbers to meet statistical significance. This one, similar one, came out in 2008. These are now meta-analysis. Meta-analysis means that no single location has enough patients to give you an answer, and so they're looking at everything that's in the literature and trying to say, okay, if we've got everything, where do we end up? And so here, there was a 78% success rate in clinical improvement versus 64% success rate in clinical improvement. If you looked at, and this is, again, opening the DURA or not opening the DURA. If you looked at Syrinx, 87% success rate versus 56% success rate. So reverse that. 13% failure rate there, 43.7% failure rate there. More than 3 times higher failure rate. But what's the conclusion? No significant difference. Why? Because there weren't enough patients in either arm to meet statistical significance. And that was true. So I still had this discussion. I would always like to do everything we can to get by with a single operation if we can. And so that's why I always recommend opening the DURA. That was the exact discussion I had until a year ago. And this article came out that looked at, again, another meta-analysis. So almost a decade, 9 years after the last meta-analysis. And this was the first one that showed statistical significance or clinical improvement for opening the DURA. Still, they say, current evidence in the literature is of low to very low quality. What does that mean? We're not all using the same words. We're not all comparing apples to apples. We're doing the best we can with what we have, but we need places like CSF to create databases so that we're comparing apples to apples, oranges to oranges, and we know where we're going. So this is the logic on why I open the DURA, knowing 60 to 70% of patients are going to get better if you don't open the DURA. So we're opening the DURA in 60 to 70% of patients, trying to get to that 80+%. What's the downside of opening the DURA? The DURA keeps the spinal fluid in place. So if you open the DURA, there's a risk of a spinal fluid leak. That risk is at least 10 to 15%. If you develop a leak, you need to have often another operation. Not always, sometimes they'll heal up on their own, but often you need to have another operation. One of the reasons that the pediatric neurosurgeon is particularly interested in posterior fossa craniotomies is the most common solid tumor in kids is brain tumors. Kids get more brain tumors than lung cancer, liver cancer, or anything else. And the most common location is the posterior fossa. So one of the more common craniotomies I'm doing is a suboccipital craniotomy for a brain tumor. So it's the Chiari decompression, except you're taking out a tumor instead of decompressing the Chiari. But the approach is the same thing. The risk of spinal fluid leaks in the brain tumor patient population is very low. It's much higher in the Chiari patient population. Why is that? We don't know for sure, but we know when we go in and we see CSF leaks, it's almost always a stitch that pulled out. So in my opinion, there's 2 things going on in the Chiari patient population. One is we're doing it for pressure. So sort of like water on a stone. You've had pressure on your DURA for a long time, it doesn't hold a stitch as well. And 2, we know that connective tissue disorders are common in the Chiari patient population. So EDS, Ehlers-Danlos syndrome, is a very trendy diagnosis currently. 10 or 15 years ago, we were diagnosing the same patients with fibromyalgia. Part of my frustration with Ehlers-Danlos is there's no good treatment for it, and the diagnosis is really a clinical diagnosis as opposed to, say, rheumatoid arthritis, where you have a rheumatoid factor to look at. So it's my opinion, and this is just opinion, but having walked this pathway for 25 years, now I suspect 10 or 20 years down the road, we're going to find that what we're calling EDS now is really 10 or 20 different diagnoses, that there is some genetic piece to it. There is certainly a connective tissue disorder piece to it, But whether it's all EDS or not, that's just what we're calling it now. EDS was a very rare diagnosis 10 years ago. And at least half of the patients who come into me with Chiari now have the EDS diagnosis. So this is sort of historically interesting for me. So let me take you a brief sidelight to tell you we're still learning a lot of things, so simple things. What dural patch graft should you use? If you look at most tissue that's implanted in patients, certainly solid organs, you use cadaveric. Skin, you use cadaveric. Eyes, you use cadaveric, right? You use it harvested from donors. Why don't you use cadaveric dura? We did until the 60s, and then certain disease processes were found. Creutzfeldt-Jakob disease, Kuru disease. Those are from prions. So prions are self-replicating proteins. It is a very specific disease process, but they are only in the central nervous system. And if you take central nervous system from one patient and put it in another patient, there's a risk of spreading that disease. So we never use cadaveric dura. You won't hear people talking about doing that. So remember, I matched in 1990. When I was doing Chiari's in my training, we used bovine pericardium on everybody. For those of you who are old enough to remember, from an idiosyncrasy of the health delivery system, almost all the bovine pericardium, so covering of the heart from cows, has a texture similar to dura. So that's what we were using. For an idiosyncrasy in the healthcare system, almost all of the bovine pericardium that we were using in the 90s was coming from Britain. Britain was the epicenter of mad cow disease. Mad cow disease is a prion disease. So there were cases of mad cow disease spread to humans in Europe, none in the US that I'm aware of. So we stopped using bovine pericardium. And that led us to then using, there's a lot of synthetics now. They've gone back bovine pericardium. They figured out how to treat it, so some people are still using that. But it also led a lot of us to use autologous tissue. So in my mind, if you're using your own body's tissue, you don't worry about rejection. Theoretically, the risk of infection is lower, although again, that doesn't meet statistical significance, so we don't know that for sure. But there's lots of different things you can use. So the pericranium is the covering of the skull, the covering of the cranium. The fascia lata is from your leg. And then, like I said, I've been using autologous cervical muscular fascia for about a decade. When I was in Florida, I got a new partner about 7 years ago. He said, you got to write this up. I've never seen anybody do it. I said, it's so obvious. I think everybody should be doing it. Well, it was just 2 months ago that Dr. Menezes, who's sort of one of the grandfathers of craniovertebral junction anomalies in Iowa, wrote up his 10-year experience with using autologous cervical muscular fascia. So more and more of us are using that. Again, we don't have the right answer. We really don't know for sure what the right thing is. And we haven't figured out how to minimize the risk of spinal fluid leaks. That's what we're worried about primarily when we open the dura. So we talked about bleeding, infection, failure to improve, spinal fluid leak. Bony regrowth. Bony regrowth, very rare in the adult population, more common in kids. I can keep talking, but oh, there we go. More common in kids. So kids have smaller heads. We can't do as big a decompression in kids as we can in adults usually. So size is an issue. If we can't, the body's natural tendency is to close a hole that wasn't there in the first place. When we're doing the decompression, we're making a hole that wasn't there in the first place. Kids tend to heal better than adults as well, so they tend to close that up. And their skull is still growing. So, so what does this mean? Dr. Scott is one of the grandfathers of pediatric neurosurgery. He's up at Boston Children's Hospital. When we hosted a Chiari retreat about 7 or 8 years ago, they came down and gave their experience with decompression in young kids. And in their hands, I've never seen it published, but in their hands at this presentation, they talked about 50% of kids under the age of 5 needing to have a repeat decompression. That led me to go back and look at my numbers. And in my hand, 2 is about the magic, 2 years of age is about the magic cutoff. There, you had a much higher incidence. 70 to 80% of those kids needed a repeat decompression. At 2 years of age, your skull is about 90% adult size, so you can usually get that 2.5 centimeter by 2.5 centimeter suboccipital decompression that we talked about. So 2 was sort of my magic cutoff, but somewhere between 2 and 5 is what most pediatric neurosurgeons will talk about. And certainly you need to follow them along to make sure there isn't significant bony regrowth in between the 2. We've talked about associated diagnoses. I'm not aggressive in my workup with EDS. I treat every Chiari patient as though they have a connective tissue disorder, whether we label it EDS or not. The truth is there's going to be healing issues. There's often hypermobility issues. And it means that you use slightly different stitches, you use longer lasting stitches, you use things to try to give the body extra time to heal. Idiopathic intracranial hypertension is something that we're seeing a little bit more frequently now. It's probably present in about 5%, but again, we don't have statistical significance to these things, but in about 5% of Chiari patients. So idiopathic intracranial hypertension means that the pressure is going up inside your head, but the ventricles, the fluid-filled spaces in the middle of the head, aren't getting bigger. So for most patients, when you develop pressure inside your head, particularly if it's fluid-related, the ventricles, the fluid-filled spaces, get bigger as well. For a fraction of patients, they get idiopathic intracranial hypertension, idiopathic because we don't know what causes it. And so we may miss that in some patients. Their head MRI will look normal with the possible exception of the Chiari. Why do they get a Chiari? Because their pressure inside their head is up and something needs to give. There's one hole to push the brain through, and that's the foramen magnum, so you'll get a secondary Chiari. So these are, when we open the dura, we'll see if there's significantly elevated pressure. We're able to follow along. And if you have true idiopathic intracranial hypertension, there's a higher risk of a spinal fluid leak. So that's usually how it's picked up in this patient population. And then craniovertebral instability, again, more common in the connective tissue disorder patient population. So the treatment for true craniovertebral instability is fusion. It's important to occipitocervical fusion. It's important to pay attention to somebody who's done that a fair amount and somebody who's done it in the Chiari patient population. So I've been here all of 3 months. I've already seen a patient who had a very good fusion done elsewhere, who was having unremitting headaches, and she was having unremitting headaches because her skull wasn't normal. Skull was thinner. They used a normal size, this is an adult patient, used adult size screws, and 3 of them pierced the dura and were causing brain irritation from that. Again, just important to know that somebody's paying attention to all these things. So what happens if surgery doesn't improve your symptoms? Again, you want to be sure you're not missing an additional issue. So easy thing is you want to make sure you do a head MRI. Is there a spinal fluid leak? Is there anything like that? If there's a spinal fluid leak, you do everything you can to get it better, but sometimes you need to go in and fix it. Going in and fixing it means that you put a stitch in the dura. It's almost always a single stitch that pulled out, so you put a stitch in the dura. If that's all you do, there's no reason to think it's any better than the first time you did it. Hopefully you were happy with the dural closure the first time. So in all of my patients with spinal fluid leaks, I put a lumbar drain in as well, which means we do a spinal tap, and we are able to drain spinal fluid out for typically about 3 days. Once we clamp it, it also lets us monitor intracranial pressure, so making sure that we're not dealing with idiopathic intracranial hypertension or any other secondary causes of that. Obviously, you're looking for instability. Instability is pretty rare to diagnose on static films, meaning that most patients have pretty good positioning, and so you need to do dynamic films, flexion and extension, ideally flexion extension MRI, because you want to see how the spinal cord looks in relation typically to the dens in the front. But you want to make sure that you want to see if there's any changes there, so you need some dynamic films. Flexion extension films are ideal. And then we talked earlier, this is the setting, if they're far enough out, that I like using a cine MRI. If we see obstructed flow, we have a discussion of potentially re-exploring. We talked about in the ideal circumstances, you're at 80+% success rate for your first decompression. For a redo decompression, particularly if it's for scar, you're down at best at 50%. We haven't figured out how to stop scar from coming, so we've used lots of things. We've used Teflon. You saw all the different dural patches. There is a product called AmnioFix out there now. The amniotic tissue from mothers is the only human tissue that sees 2 genomes, baby and mom. So denatured amniofix is FDA approved for epidural scarring outside the dura. Question is whether it will help intradural or not. Nobody really knows that yet. But so there are things that we're looking at, but we really are just in our infancy for learning these things now. We talked about syringomyelia. If you open the dura, you're successful about 90% of the time. We didn't understand that when I started neurosurgery. We were shunting a lot of patients with Chiaris and syrinxes because we saw the syrinx was symptomatic, we would shunt them. This was standard of care in the 80s and 90s. We now understand that there is a relation to the Chiari, and we know that a Chiari decompression will be successful more than 80% of the time. It's important to define a syrinx. So MRIs are so sensitive now that we'll often see a little bit of fluid in the spinal cord. A 2 to 3 millimeter syrinx is usually, a fluid collection in the spinal cord, is usually not considered a syrinx. And one of the reasons is we can't do anything about those. So when we used to shunt patients, the size, the diameter of the catheter was 3 to 4 millimeters. So a 3 to 4 millimeter syrinx was considered a successful treatment when we were shunting these patients. And so that's about as good as we can get. We really try to avoid shunts now. So I'll probably do a patient with a Chiari and a syrinx once or twice a month. I'll do a syringo somewhere. I usually go subarachnoid. You're just trying to get the fluid out of the spinal cord. Subarachnoid means it's just going to the outside of the spinal cord, which is where it belongs, every couple of years. So it's pretty unusual. The reason you want to avoid that is, remember, almost all the operations we're talking about are really skull and around the brain. For a syrinx, you're talking the middle of the spinal cord. So there's a much higher risk of hurting the spinal cord, and usually it's cervical. So you're talking about not just arm and leg, but breathing issues as well. And so if you can avoid that, you really want to try to avoid it. If the syrinx hasn't gotten better, the first easy thing to do is make sure you did an adequate decompression. So we'll see a lot of patients with syrinxes who the dura wasn't open, and so you fell into that 50 to 60% success rate versus that 80+% success rate. I'm going to go just on a couple of comments because these are things that I often get asked about. So, and let me tell you my biases. People remember 3 things about me. I'm a neurosurgeon, I was a rocket scientist undergrad, I was an aerospace engineer undergrad, and I have 7 kids. So the reason I mention that 7 kids puts me on the very liberal side. My goal on these treatments is to have people lead a normal life. So the goal is to have you lead as normal a life as possible. That includes delivery, okay? So Chiari and pregnancy. This came out about 1.5 years ago, and it was in one of our smaller journals. The International Surgical Neurology Journal is not one I even get, okay? I don't know what their publication is, but it's got to be very small. This is the type of stuff that I see online. But they did a very interesting study. Again, this is their routine. This is not something that has been scientifically shown to be helpful, but it makes sense to me, and it's what I teach my OBs now as well. So if you have obviously if you don't have a Chiari 1, not a big deal. If you have a Chiari 1, is it symptomatic? If you're not, then you go through these others. There's 1 point for all of these. If you have 1 or 2 points, a neurosurgeon should probably be seen, but I let these patients go through vaginal delivery. The reason vaginal delivery is a concern, we talked about Valsalva maneuvers. It's about the biggest Valsalva maneuver anybody's going to do in their lifetime. And so I've never seen anybody injured by a Valsalva, by a vaginal delivery. I have seen some patients' symptoms get worse. And so that's the type of thing that we need to watch for. If you have something we worry about, remember, if we consider this a cork and the cork is getting tighter, if you have syringomyelia, so in the spinal cord, particularly if you have syringobulbia in the brainstem, we worry about making that worse. And so again, we want to prevent anybody from falling off that cliff if we can. So while I am relatively liberal in my allowing patients with Chiaris to do vaginal deliveries, That's not true in everybody. So what's the option? The option obviously is C-section. Then you have a discussion about C-section. What's the right kind of anesthesia? So most get spinal epidural anesthesia. But if you do get spinal epidural anesthesia and you go 1 millimeter too far, you get a wet tap. You get spinal fluid leaking out. If you've got spinal fluid leaking out and that persists, you can pull the Chiari down. So you get into this cycle. It's important to have the neurosurgeon part of the discussion. The other thing we get into a little bit is activity. So remember, you're talking to the guy who lived in Orlando for almost 25 years. Everybody was riding roller coasters and doing all that stuff down there. I fall very much on the liberal side. My goal is to have patients lead a normal life. So again, normal, and then the cerebellar tonsillar ectopia. So what's supposed to be there is CSF. What's there in the Chiari patient population is brain. Brain does not have the same forgiveness as spinal fluid, so you have less of a shock absorber capacity. There is a theoretical risk of injury to significant flexion extension. You don't have the same shock absorber capacity. So you will have some neurosurgeons, and again, it's just, are you conservative or are you liberal? There's not good literature on this right now. Some neurosurgeons who say, shouldn't ride roller coasters, shouldn't have a vaginal delivery, shouldn't play contact sports. I can tell you I've had kids play football who had Chiaris, both decompressed and undecompressed. When you're decompressed, we're giving you more space, so you're theoretically safer, but surgical repair is never as good as not needing surgery in the first place. We keep looking for case reports of patients with Chiaris who have been injured. We just haven't seen it. So it is a theoretical concern, not a proven concern. And again, because I fall on the liberal side, I want to have proven concerns if I'm preventing patients from leading a normal life. So with the theoretical concern, I let patients do pretty much everything with, again, the caveat. If you're doing something and it hurts, stop doing it. If it's causing Chiari symptoms worse, Chiari is never a no pain, no gain situation. If you're having pain, you need to stop doing it, whatever it is. And often, that's roller coasters, axial loads, so riding horses, riding ATVs, long car rides, that type of stuff can be worse as well. So again, we talked about CSF. This is a piece of their mission statement. We're learning more, but we're still in our infancy. One of the reasons I became a neurosurgeon, the two surgeries you can match into, that you can train into, that have the longest training are neurosurgery and cardiac surgery. With cardiac surgery, we can replace the heart, right? We can do heart transplants. We're not going to go a whole lot further in cardiac surgery. We'll get some better tools, we'll get some better medicines, but we can replace that organ. In neurosurgery, we're still in the dark ages. We're still just barely learning. You hear people say you only use 10% of your brain. We only understand what 10% of the brain does. It doesn't mean we only use 10% of it. We certainly don't want 90% of our brain removed. And so we still are very early on in our knowledge. We are getting better. MRIs are showing us better anatomy. We're getting there, but we've got a long way to go still. So I use this as the end for two reasons. I used to have all my Disney pictures here. Now I've got my South Dakota pictures here. But for a guy from Minnesota, so again, I was born in Minnesota. This is the first time I'm living in South Dakota. This is sort of what I think of when I think of South Dakota. And you guys may all know this, but this was interesting to me. When they were originally building this, Jefferson was to Washington's right. The quality of that rock was inadequate, so that's why Washington's actually sticking out and Jefferson's in. This was sticking out, and they dynamited all of it because they weren't happy with the quality of the rock. They didn't think it would last. So we are still, I think, working on Jefferson over here, and we're trying to get the whole Mount Rushmore of Chiari figured out, and we're a long way from there still. So I appreciate everybody's time. I will stay here as long as there are questions, and I'll open the floor if there's any questions that you want to ask in the group, or like I said, I'd be happy to take individual questions. You think everybody can hear you? We'll try this.
So in one of your slides, you were saying that with the Chiari 1, you're born with it. Are you always born with it, or can someone develop a Chiari malformation?
almost all of the time when we go back, we see it if we have old MRIs. The degree of cerebellar tonsil ectopia can be more, and there are acquired Chiaris. Thank you. There are acquired Chiaris as well. So we think most are born with it, but certainly not all are born with it.
Okay. And if you do have a decompression, should you have like follow-up MRIs?
In my opinion, yes. In the literature, I don't know. So I'll tell you what I do. I repeat an MRI at about 3 months out. So I keep all my patients in light duty for 3 months. I don't want any heavy lifting. I don't want them to be in the same position if they're computer workers or something like that. I want them to be able to take a break every 30 to 60 minutes. Again, the logic is you're not fully healed until you're about 3 months out. Any significant valsalva, you're putting stress on the stitches we put in there with the dural opening, and you're theoretically increasing the risk of a spinal fluid leak. I repeat an MRI 3 months out to make sure everything's okay and to make sure there is no spinal fluid leak. If you don't have a leak at 3 months, you're not going to get a leak. Your risk should not be any significantly higher. So again, one of the reasons I like to open the dura is all the risk is sort of at the front end, and you're then got gravy on the back end. And so if the MRI looks good at 3 months, then I clear you for all activity without specific neurosurgical precaution. And then I like repeating an MRI a year out more than anything. It means that I'm interfacing with the patient again a year out and trying to see if there's anything going on. And then usually at 2 years. So I do it at 3 months, 12 months, 24 months. No literature to say that that's better than never doing an MRI. It just makes me feel better, usually makes the patient feel better, makes me feel that I'm not missing anything, and then lets me follow the patient along. And then if they're doing fine at 2 years, then we just follow up as needed after that.
And then, so can your herniation, can the tonsils herniate like even after the decompression more?
It should not if you do an adequate decompression. So that's why I was saying that 2.5 centimeter by 2.5 centimeter suboccipital decompression. If you picture the skull as being a circle, you're trying to open it up enough so that you've decompressed in the midline, but you still have shelves on either side to hold the cerebellar tonsils in place. If you do too big an opening, you're just creating a space for the cerebellar tonsils to fall into. So you want to do big enough you're decompressed, but not so big you fall into the hole. And that's that 2.5 centimeter number. That's pretty good in the literature.
I don't need that. I'm
okay.
Fine. Is that the same follow-up that you do for the pediatric patients that are right about that 2-year range?
So my answer used to be yes. About 2 or 3 years ago, the American Academy of Pediatrics came out with recommendations not to do elective anesthesia in patients under the age of 3 because of the theoretical concern about anesthesia in very young kids. So I usually try to wait until, I don't like operating on Chiaris under the age of 2 because there's a high risk of needing another operation. So the only time I really do that is if they're myelopathic, have central sleep apnea, have something I worry about significant issues with, feeding issues. And so in that case, usually I'm doing them after 2, and then I'll repeat an MRI when they're a little beyond 3 years of age. So I'm a little bit more liberal on that only because of the American Academy of Pediatric recommendations. Yes?
So I know you mainly focused on type 1.
Yes.
Type 2, how different than type 1?
The treatment is the same, the anatomy is different.
Okay. Is that because most of them are dealing with those that are born with the myelomyelitis?
Yes. Yes, so the anatomy is different. The decompression, the surgery is identical. About 80% of patients so the vast majority of patients with spina bifida have a Chiari 1 malformation. There was the MOMS study, which was in utero closure of spina bifida. One of the things that it improved to a statistical relevance was it reduced the incidence of Chiari. That's not that huge a deal because more than 80% of patients with spina bifida and Chiari are asymptomatic from their Chiari. So eliminating an asymptomatic anatomical abnormality is not a huge jump, in my opinion, not to belittle the MOM study.
I have a question. They were talking before you started your presentation. Could it be that a lot of people that have headaches may have this condition and not know it? And if that's the case, should general practitioners know more about it so they might be able to diagnose it?
You're talking to a neurosurgeon. I always like looking at patients' insides. So I say, yeah, I mean, I can tell you in my personal case, I've got a daughter with headaches. I did an MRI on her. She didn't have a Chiari, but I wanted to be sure we weren't missing something else. Yeah, I mean, we are imaging so many people now. The truth is, again, the vast majority of patients with headaches have normal MRIs, but you don't know unless you look.
If there is the spinal leak from the dura, then the doctor has a shunt, is that right, that has the fluid go to the stomach? Is that the normal?
You can put a shunt in, but if it's a post-operative CSF leak, you really want to try to stop the CSF leak as much as possible. So again, in my case, I put a stitch in and then I put a lumbar drain in to make sure the pressure is okay. So the lumbar drain lets it drain out for a couple of days, so there's no pressure on the new stitch for a couple of days. Then once we clamp, we make sure that there's no idiopathic intracranial hypertension. If the pressure is up, you are obligated to put a shunt in because you're not going to stop that leak as long as the pressure is up.
Heather is one that has one of those things.
Yeah, so shunts are relatively common, and if you have a recurrent CSF leak, you'll often put one in because you're trying to lower the pressure inside the head, and again, you're just trying to get the pressure intradurally, where the CSF is coming out, same pressure as outside, so you get a chance to heal.
Is there a danger of infection in the brain if there's surgery then in the stomach area where that might?
Pretty low risk. So the most common pediatric neurosurgical procedure in the U.S. is a ventriculoperitoneal shunt. We didn't exist as a subspecialty in pediatric neurosurgery until shunts were invented in the 50s and really popularized in the 70s. So anytime you have a foreign body implant, there's a theoretical risk of infection. That risk is in shunts is about 1% per year. It's a one-way valve, so it's not that CSF can come back into the brain and cause issues. If the shunt gets infected, usually stays infected if it's an abdominal infection, usually stays in the abdomen, but you do need to pay attention because it certainly can creep along the shunt itself and cause meningitis. That would be pretty unusual. Possible, but unusual. And so usually it's something you've been ignoring for a while. So again, just important the neurosurgeon knows.
How many patients have you seen present with what they used to call pseudotumor cerebri, and then 10 years later say, oh, you have a 9mm Chiari?
Yeah,
so
a lot.
Decompression.
So pseudotumor cerebri is idiopathic intracranial hypertension. Right. Pseudotumor cerebri is really a pre-MRI era, so diagnosis, you don't hear us use that terminology as much anymore. It looks like you have a tumor. You have papilledema usually, swelling behind the eye. You have headaches. It looks like you have a tumor, but we don't see a tumor. And so we know that there is no tumor when you do an MRI. Yes, that is a common issue. The ideal situation is if you have previous images, hopefully by putting the shunt in, you're changing the pressure dynamics, and then those patients, if you have a working shunt, you'll often see ascension of the cerebellar tonsils.
What if they put in a lumbar shunt instead of ventricular? This is my case for myself, is I started out with the diagnosis of pseudotumor, and 10 years later they say, oh, you have a Chiari, and I hadn't heard that, but I had imaging through that whole time.
There is clear literature that LP shunts have been shown to cause Chiaris. So we talked about most patients being born with them. It's very similar to spina bifida. If you've got continuous spinal fluid leak in the spina bifida patient population, it's going into mom's amniotic fluid for 9 months or however long they're pregnant. In the LP shunt patient population, you're sucking things down. So personally, I like LP shunts in the cases of idiopathic intracranial hypertension. The advantage is you've got a bigger spinal fluid space, so you've got about a 50% failure rate in shunts, VP shunts, in the idiopathic intracranial hypertension patient population because your target is smaller, so it's more difficult to get it in. But if you have EDS, if you have other issues, if you have a connective tissue disorder, we know that LP shunts can draw the cerebellar tonsils down. Now, I say that, and I've got a couple of patients in my practice who have both, had the Chiari decompressed, and had serial VP shunt failures, so we ended up putting an LP shunt even in the setting of Chiari, but I follow them very closely to make sure that there's no further cerebellar tonsillar ectopia. So Chiari is a relative contraindication to an LP shunt though.
What if because it wasn't diagnosed as a Chiari first, so they do an LP shunt because...
So I don't want to tell anybody what to do, but you want to change, no. But theoretically, you want to change the pressure dynamics. This is glorified plumbing. I mean, this isn't brain surgery. I don't want to belittle what we do, but it's not brain surgery. You've got pressure that's sucking things down. What do you want to do? You want to change it and suck things up. How do you do that? A VP shunt. Knowing you've got a 50% failure rate. But as long as that LP shunt's there, you're going to keep pulling things down.
Well, and eventually it got switched once I went to someone who
Yes.
had an
Yes.
idea of what that was. But
It's half of what I do is glorified plumbing. It's fancy plumbing, but it's glorified plumbing.
Have you seen a lot of, like you were talking about fusions and stuff, have you seen a lot of post-Chiari? Our youngest son had a decompression at 2. He was way far into the feeding issues. So by the time we did it, he's on high doses of gabapentin for all the nerve pain we still deal with. But we just had flexion extension MRI done, and he's got movement between C2 and C3. He also was diagnosed with classical erosion.
Yeah, I would blame that on the connective tissue disorder, not on the Chiari, although it's all same spectrum. But particularly in kids, it's actually pretty unusual. So kids have stronger ligaments in general, and so it's why there's a right. Well, some don't because they have connective tissue disorder. But trying to think, it's exceedingly rare that I have. I think so I finished my fellowship in '97. I think in that time I've seen one kid that really had a decompression that needed a fusion. I've seen many adults.
Yeah.
Kids, you just don't see it as often in.
Are the risks greater or less for an adult surgery as opposed to I know you had several factors up there, but what would you say is the greater risk, adults or children?
Adults tend to do better.
They do better.
Let me rephrase that. Adults tend to recover better. Kids long-term do better because you're catching it earlier.
Yeah.
So it's just sort of common sense. The sooner you catch something, you want to catch something in that 81% versus that 58%, if you remember that Chiari severity index.
Well, the kids can't tell you.
That's part of the frustration.
So your symptoms
Exactly.
are more, they can get worse.
Correct. So the under 2-year-old patient population, maybe under 4 or 5, is different because, again, you're usually catching them further along with their symptomatology, so where they're having feeding issues and those types of things. If the adults are having those issues, they don't do as well either.
Could a pseudotumor cerebrate cause a Chiari malformation?
Anything that increases your intracranial pressure can. So we'll often see cerebellar tonsillar ectopia. For instance, we talked about brain tumors in the posterior fossa. Almost always they'll push the cerebellar tonsils down. That's not really a Chiari per se because once we take the tumor out, they come back up, but it's the same type of pressure phenomena. You'll see it in a lot of congenital hydrocephalic patients. Anything that increases pressure in your head, pseudotumor, idiopathic intracranial hypertension, the brain's going to look for a way to decompress itself, and the only hole it can go through is the foramen magnum.
Does insurance cover your MRI 2 years out without problem?
Insurance doesn't cover anything without problem. I don't know if I want to say it on camera, but nobody says no to the pediatric neurosurgeon, so I might have to jump through some hoops, but we always get it done.
Okay.
Yeah. I'm sorry, just a quick anecdote. I'll get to you, I promise. I sold my practice 10 years ago. I was in private practice for 10 years. I've been an employed physician for the last 10. I used to have contracts that I didn't have to do pre-authorization because they could look at my past 15 years and say, okay, we never denied Trumble. We made him jump through some hoops sometimes, but we never denied Trumble. Those just don't exist anymore. We've seen more and more difficulty. It's one of the reasons that I like being an employed physician because I don't want to deal with the insurance stuff, quite honestly. Just a brief anecdote there. Yes?
So for those that have the Chiari malformations that are asymptomatic, at some point in time, can they become symptomatic?
Yes. Yes, and so that
How often do you see that?
well, we don't know because we don't know how many people, we see a lot of adults who become symptomatic. We assume that they had Chiaris younger, they just weren't imaged before. So we really don't know that answer, but I see a lot of patients with minor issues, box falls on their head, you know, something that's causing flexion extension that initiates the symptoms getting worse. So if you have a Chiari, I do think it's important to pay attention. I told you I'm liberal. I let patients do everything, but I do try to say use common sense. If you can, you know, avoid doing gymnastics and do, you know, softball. If you can not climb that tree, you know, if you can not ride the roller coaster, sort of use common sense. You're not a China doll, but you're at slightly more risk than somebody who doesn't have the Chiari. Thanks again, everybody. We'll let Kathy.
Yes, thank you so much, Dr.